Okay, guys, this should be the last one. Bear with me while I get this up, and I promise you this one is going to be very short and very sweet. Okay, it's on musculoskeletal trauma and surgical procedures. Y'all know what contusions, sprains, and strains are. Your medical management for all three of these is going to be price. Remember, protect, rest, ice, compress, and elevate them. You need to see the chart on page 1522, which grades the sprain severity for you. Okay, this is one of those nice to know things. It is not a need to know for the test. Your patient teaching of exercise for strengthening and mobility and prevent injuries. You need to see that patient teaching on page 1524. Okay. Make sure that throughout all of these chapters that you pay close attention to the safety alerts that are in the chapters. Dislocations. A dislocation is considered an orthotic emergency. You must know this and know what they will do for deformities. The signs and symptoms, you're going to see a deformity of that extremity. Like I said earlier, though, it might not be severely deformed. It might just be a little bit a little bit dislocated, so it can be hard to tell. With severe deformities, you're going to have to watch for decreased sensation in circulation and closely monitor the joints distal to the injury. IV analgesics are going to be ordered because these are very painful, and in order to put it back into place, the doctor will have them hopefully with some conscious sedation so they do not feel as much pain. It needs to be treated within 15 to 30 minutes if at all possible in order to prevent there from being so much edema that they cannot get it back into place easily. And if it's been longer than 30 minutes, more than likely they'll have to go under general anesthesia to get it put back into place. Fractures, you need to know your classifications of your fractures and how to grade them. That's on page 1527. Initially, your management, as far as nursing goes, you're going to want to make sure that you assess the capillary refill, assess peripheral pulses. You want to do all of your neurovascular assessment. You want to immobilize the fracture in the joint and the bones above and below the fracture site. Narcotics will be given for pain relief. They may have casts, they may have traction, they may have to have a surgical repair with internal or external fixators or rods placed. And your book goes into this just a little bit. On casting, your book does not go into this very much, so I want to talk to you about cast. If they have plaster cast or fiberglass cast, this is the most inexpensive way to stabilize fractures. Plaster cast, you need to know that with casting that there should be a restriction of the joints above and below. The patient will also experience some muscle atrophy. Swelling can be typical for 3 days after the fracture, so they need to keep that arm elevated. You need to monitor that cast and teach your patient and your family members to monitor the cast for tightness due to that swelling, because they could develop complications like compartment syndrome or cast syndrome. It takes 10 to 14 days for granulation to start on the bone. Cast it's going to depend on your patient on how long the cast stays. If it's a plaster cast, it will require 24 to 72 hours to dry completely. It will feel dry within an hour or two or appear dry, but it is not thoroughly dried. You want to make sure that it is placed on pillows. It's not placed on a hard surface, because any dents that are left in the cast can cause ulcerations to the skin underneath that cast. You want to make sure that there is pedaling done on the cast, where they take and they pull the rough edges and roll it down to where it's not up against the skin. Also with cast, they may have to be bivalved if they become too tight. The doctors will do this on occasion, or if they have a wound underneath that cast that they need to get to. And bivalving is where they just take and they go down the medial and the lateral side of the cast, and they split it in half, and then they can remove the cast and place the cast back on and hold it together with ACE wraps. They can also put windows in cast where they will go in and they will open up a small area and keep that area. You do not discard it to where the window is permanently there. You will keep that portion of the cast that they cut off, and it will be placed back on and wrapped with an ACE wrap to hold it in place when you're not doing wound care at a certain site. They can cause skin breakdown, and they can cause at pressure points. When casts are applied, there should be extra padding, especially over the bony prominences. They will put a stocking net on, and then they will put cotton down underneath the cast. And in the areas where there are bony prominences, such as if you're casting the foot, at the heel, and at the ankle, you would want to ensure that there is extra padding at those areas. Fiberglass casts are lighter weight and they're quicker drying. A Gore-Tex liner can be used for waterproofing of cast now. A lot of your fiberglass cast in your Gore-Tex cast are allowed to shower and swim. It takes a little while for them to dry. If a cast does get wet, you need to apply a cool hair dryer, blow dryer, to blow down the cast. If there's itching, the patient can use a cool air dryer, blow dryer, to blow down the cast to help alleviate the itching. Of course, nothing should go down that cast. No scratching, instruments of any form or fashion. When you have children, you want to make sure that they don't have any little marbles or anything that they can stuff down the cast. The fiberglass and the Gore-Tex casts only take about 20 minutes to dry. They're used more often anymore. They are lighter weight. You can get them in all sorts of decorative patterns and colors. On the plaster cast, or even the fiberglass cast, if they are kept on for an extended period of time, you need to educate your patient on what is normal when that cast is pulled off. It would be normal to see some really dry, flaky, sloughed off skin, and for the muscles to be smaller on that arm or leg or extremity than on the other side. And this is normal, and you need to teach your patient that it's to be expected, and that muscle tone and strength will go back towards their normal when they get some therapy and use it more without the cast in place. Okay, you need to teach them post-cast care of removing scaly dead skin carefully. Soak it, don't scrub it. You do not want them opening up the skin in any form or fashion. Tell them to move the extremity very carefully for a few days. Expect some discomfort, expect some weakness, expect decreased range of motion to that extremity. You want it supported on pillows. They might have to have an orthotic device until the strength and movement returns. Exercising should be done slowly or started slowly, and it should be under the instruction of a physical therapist. They may also need to use some support stockings or elastic bandages of some form or fashion to help decrease swelling after the cast is removed. Fracture management devices, you could see skin traction or Buck's boot tractions. Miss Enlos has gone over these with you. They're for hips. No more than 6 pounds should be put on them. Monitor that skin every 4 to 6 hours, where the boot is or where the pelvic strap is, if it happens to be Buck's for the pelvis. Skeletal traction, the pins are going to drill directly into the bone. They exit through the skin. They connect to a bale that serves as a counterweight. Okay. It brings that bone into alignment. Pin site care is vital. Please be well versed on the pin site care on page 1529. It is best practices. It's evidence-based practice. Pin site care is what it is called, and it is the best practices on how to do pin site care. You can have complications with skeletal traction of skin breakdown, UTIs, pneumonia, DVTs, PEs, site infections, and osteomyelitis, because those are just a pathway directly to the bone. On your Buck's traction and your skin tractions, your number one nursing priority for those is to make sure that those weights stay off of the floor, because you are not applying traction if the weights are down on the floor. External fixators are the treatment of choice for many fractures because they allow you more mobility earlier on. That pin site care and pin infections are another one. You can also have plantar flexion contractures that tend to be a complication from this. Open reduction and internal fixation, they use plates and screws and wires to hold the bones together. Of course, complications can be infections and hardware failure or breakage or allergies to the hardware. Intermedullary rods is a fracture fixation that entails putting a metal rod down through the medullary canal of the long bones to fixate the alignment. It's used in segmented fractures. Of course, the complications can include stress risers from the screws, which means that there are pits in the bones, and there's gaps that can lead to osteomyelitis. Rod removal, increased risk of fat embolism because you're drilling into the bone and can release some of the fatty tissue. Pelvic fractures, a lot are caused by MVAs. It's common associated problems of femoral fractures. You're going to see bladder ruptures and risk of retroperitoneal bleeding with these patients. Your clinical manifestations, your diagnostic tests are here. Please know that the x-rays are an AMP of the pelvis inlet at a 60-degree angle. You're shooting from the head of the bed for that, and an outlet view is a 45-degree angle, and you're shooting from the foot of the bed for that. You need to look at the labs and diagnostics on page 1533 for these. You're going to see decreased red blood cell counts, hemoglobin, and hematocrit, and they're going to demonstrate bone loss and fracture and tumor on CAT scans. Okay. I want to just take a moment here and make sure that I've gotten everything. On casting, patients with cast, you're going to see an increased ESR. That this could be the number one indication of an infection underneath that cast. So if they do have a cast on and they have an increased ESR, you want to check their temperature and their vital signs, of course. After the swelling has gone down, the cast may slip. If the cast is easily movable on the arm or the leg, wherever the cast is located, this is considered a point where these patients need to come into the physician's office and have the cast replaced, because it will not be effective and the bone will not heal appropriately to the fracture points. Okay, so they should have that cast removed and another one placed that fits snug. Like I said, I'm trying to make sure that I cover all of my points that I need to with y'all. Of course, everybody knows that an open fracture, be it a pelvic fracture, or leg fracture, arm fracture, any open fracture is more complicated and has a very high potential for causing or having complications due to the openness and contamination in the wound. Okay. During your assessment as a nurse, any deficits that these patients have that have fractures need to be reported immediately to the doctor, because they could become a permanent deficit. For any type of fractures, that they're also going to have a lot of narcotics for pain relief. They're given in small, frequent doses. Okay. You need to monitor these patients, especially the ones with open fractures or with skeletal traction or with rods. Monitor them for infections. Like I said, your pen site care. If you suspect someone or you see dry, crusty exudate around the pins in skeletal traction, the first thing you're going to want to do is to culture that drainage. You do not want to scrub it off. You want to carefully remove it. Okay. And know your complications from traction, such as DVTs and PEs, okay, and pneumonia and UTIs. When you have someone that has a fracture, they need a diet that is high in calcium and vitamin C and protein to help with healing. They'll be given opioids. You'll also want to elevate their extremities and place ice on them. You can ice the cast, but you need to place something between the cast and the ice pack, in order to catch any leaks. You do not want to get the cast wet, especially if it's a plaster cast. These patients who have cast will need to have isometric exercises. You need to teach them how to do isometric exercises while they have a cast in place to help prevent muscle atrophy. Pain meds are usually administered for PCA pump. Open fractures should have a sterile dressing placed on them to protect it from contamination, and you need to monitor them for signs and symptoms of infection, like I said before. Let's talk about rotator cuff repair now. you need to know that when somebody has a torn rotator cuff, one of the signs that their rotator cuff is torn will be that they will be unable to maintain an abduction of their arm, and that's ABD, abduction of their arm. What are the clinical manifestations? Pain, it progressively worsens and it's aggravated with activity. When it is the glenohumeral portion, the pain will be located in the back and it'll be worse in weather. When it is the acromoclavicular, the pain's going to be focused in the front. Lifting of their arms is going to become more difficult where they cannot get them above the shoulder level. Yeah, clicking and snapping are common. They have night pain. They'll have some sleep disturbance. Surgical management, they're going to restore the function by removing the scar tissue. They're going to balance the muscles, and they're going to replace the joint surfaces if they need to. Range of motion should be started immediately after surgery. It's very uncomfortable. They're usually discharged after 3 days. If they have to have an open surgery, arthroscopic surgery, they will usually go home, or that will usually be done in a one-day surgery center. It could take up to a full year for these patients to heal properly. Shoulder subluxation and dislocation, it can be potentially disabling. They may have to have arthroscopic surgery to reestablish the stability of that. They'll wear a sling post-op. They'll need to do simple range of motion exercises daily and do their PT. And they will probably be able to return to normal activity within 6 weeks. Grading in the arm during the shoulder dislocation, subluxation, that could be indicative that there is a bone fragment in there. Okay, so y'all need to be aware of that. In the elbow, repair, the common cause is pain and injury of the elbow includes sprains and strains and fractures and dislocations, bursitis and arthritis, and some tumors. Your clinical manifestations are pain and loss of range of motion. They can report grating or locking sensations. With arthroscopic surgery, they should have a good response. Numbness can be reported in the ring and the fifth finger due to ulnar nerve damage. MRIs are done to determine the extent of the damage. With arthroscopic surgery, they should have a report of decreased pain post-op. If they have increased pain, they need to be reassessed by the doctor. Okay. Elbow dislocations are usually seen because somebody falls with their hands straight out. Let's talk, and I have your signs and symptoms and all the management of elbow dislocation. Let's talk a little bit about carpal tunnel syndrome. Carpal tunnel is an impingement of the median nerve caused by excessive pressure. They'll have numbness and pain in the hands. It can be hereditary. It can be caused by repetitive movements. It can be hormonal changes or diabetes. They complain of numbness, pain, and tingling, mostly on the thumb side of their hand. They may have difficulty and pain with holding objects, but if they shake their hand, that can help relieve some of the pain and numbness that they have. Fine motor movements can be difficult. With advanced cases, you can see muscle wasting in the hands. A lot of times your initial assessment or your initial medical management of carpal tunnel will be steroids to decrease the swelling and to help with the pain and alleviate the symptoms. The doctors will prescribe braces or splints. Might be that they're splinted at night. If they have too many repetitious movements that they need to do, they can also wear splints during the day while they're doing those movements. Excuse me. Surgery is outpatient under local anesthesia, and it may take up to 2 months for them to get their grip and their pincher back, and complete recovery can take up to a year for these patients. Post-op, you're going to want to help prevent hypovolemia in these patients, watch bleeding complications and hypoxia and neurovascular compromise prior to them going home. You want to make sure that they are well aware of what to watch for when they get home too. If they have severe cases of wrist arthroplasty, they will have cast and immobilizers and protective splints for 6 to 8 weeks. Because of the extent of usage that everyone has in their arms and their hands, when they do an arthroplasty, the prosthetics that they put in there do not last more than 10 to 15 years at a time. Let's see. Total hips. Please be aware of the chart on page 1541. It shows you it tells you exactly what the surgical procedure is for hip replacement. You also want to look at the charts on 1442 on hip replacement and hip precautions. Please make sure that you know it depends on the approach that the physician makes during surgery on what type of precautions your patient will need, and you need to be well aware of the differences in these two, as well as the home modifications that the hip surgical patient will need to make. Knee injuries, ACL injuries, and meniscus injuries. You can hear popping sensations at the time of injury. They can have difficulty maintaining the stability of their leg. Their leg can buckle on them. It can also lock. So know that they will do diagnostics of MRIs and arthroscopics to look at these joints and repair them. When you have an ACL tear or a meniscus tear, if it's a partial tear, they will go in and they will suture it back. If it's a full tear, they may have to replace it or totally reconnected. Post-op assessment, you're going to watch for hypovolemia, bleeding complications, hypoxemia, and neurovascular compromise, as you would for any patient that's undergoing any type of surgery. They may have splints and slings and immobilizers and dressings. You need to do neurovascular assessments on the affected side, including the toes, to ensure that they have good peripheral sensation and blood flow. The length of immobility is going to depend on the type of surgery and the extent of the surgery, and it also depends on the physician's preferences. Same with total knee replacements. Please make sure that you're familiar with these charts that I've given you in the red, as well as the spinal surgeries. Look for the national guidelines of diagnosis and treatment on page 1546 on spinal surgeries. They are very important. I've given you the list of the different forms of surgery: the discectomy, the laminectomy, the pharmacotomy, lanotomy, the percutaneous arthroscopic discectomy, spinal fusions. Your nursing management on these, you're going to maintain braces and maintain strict alignment of that spine. That patient needs to lie flat in the bed according to whatever time limit the doctor puts on it. They need 2 persons to help them stand from a lying to a standing position. They do not need to bend. It may be that they're on a flip bed of some type, that the actual whole bed turns over instead of you trying to turn the patient. Monitor for complications of bowel and bladder for these patients. Maintain the NPO until their bowel sounds get back. It may have to be intermittently catheterized to help empty the bladder. Check their spinal dressings for any bleeding, any signs of central spinal fluid or cerebral spinal fluid. On that dressing, it will form a halo on the dressing, and if they do have, you need to notify the physician immediately and institute precautions, because this is an easy way for them to form complications. Excuse me. An anesthesiologist may have to come in and provide the patient with a blood patches, where they will remove blood and from the patient and place it into the cerebral spinal fluid in order to patch the hole that the spinal fluid is leaking out of. You need to encourage these patients with spinal surgery to maintain a safe body weight and exercise to promote that and strengthen their core muscles. Ideal body weight is where they need to be, no heavier. Ankle injuries and surgeries. Let me see. Most of them are caused by overuse or poor conditioning or improper fitting shoes. Tendon injuries. You're going to see severe pain, swelling, difficulty with mobility, joint instability. They'll have lateral swelling and stiffness. Of course, I've given you the diagnostics and the medical management for this. Whoop, I'm sorry. Okay, let's talk about bunions. Hallux valgus. Okay, it's the outward turning of the big toe that causes that the proximal joint of the toe to rub on shoes. It is very painful, makes it difficult to wear the shoes. A lot of times the doctors will do what they call a bunionectomy and remove that, literally scrape it off. It may be that the toes will have to be broken and pinned to realign. Hammer toes is another deformity. You'll see it's a deformity of the second, third, fourth, or fifth toes. It's where they bend in the middle joint. Okay, and they rub on the shoes, and it can cause discomfort. A lot of times the hammer toes are caused by ill-fitting shoes, which cause a muscle imbalance. Diagnosis is done by x-ray to rule out any fractures. Medical management, these people can require multiple surgeries. What they do is they'll go in and they'll break the toes, they'll pin them into a proper alignment, and they will go from there. It will take quite a while for those to heal. They will not be able to wear shoes. They will be wearing casting boots. They will have pins through the bones, so you will have to do good pin care and monitor for signs and symptoms of infection. And the doctor will also order their weight-bearing status. They can be immobilized up to 6 weeks with extensive surgery. Okay, you need to see your nursing interventions on page 1552 and 1553. Now let's talk about amputations. Amputations can be caused by several things, but the most common are PVDs, diabetes, and trauma. Meningococemia, osteosarcoma, and gangrene. Traumatic injuries are associated with an increase in the phantom pain, body image disturbance, grief, and loss. And of course, these are caused by like MVAs or some type of accident. Your traumatic traumas. Nursing management, you want to monitor the skin integrity very closely. You're going to prevent any pressure ulcers from developing. Immediate post-op, you want to elevate that stump for the first 24 hours, and then you want to maintain the stump flat on the bed, or extended when they're out of bed, okay, to prevent any contracture formation. You want to maintain a compression wrapping to prevent any edema to the stump, and that wrapping should be done in a figure-8 method, and it should be started at the distal portion of the stump and work your way up. You want to allow plenty of time for these patients to verbalize any concerns or grief and loss. See your evidence-based practice on page 1550 for this. Also, like I said earlier, if it's a traumatic amputation, they tend to have an increase in the phantom pain. Well, what do you do with the phantom pain? Okay, how do you stop the phantom pain? A lot of times you'll see the doctors will order calcitonin IV. That does help decrease the phantom pain. You want to, like I said, allow them plenty of time to voice their concerns pre and post surgery. Make sure that your patients, because of their grief and their loss, they're well aware that there's still purpose to their life, that their life was not in that one limb, that they are still a very productive person. The skin should not be pale and cool to the touch on that stump. It should be nice and pink and warm. You need to monitor that skin integrity immediately post-op. Like I said, you need to know the proper positioning. Like I've told you here, you want to elevate that stump while they're in bed for the first 24 hours, while they're out of bed, or while they're in bed after that first 24 hours. It should be lying flat on the bed, or it needs to be extended if they're out of the bed. Okay. Make sure that you know to perform a neurovascular assessment distal to the surgical site using the 5 P's. And those 5 P's are pain, pulse, paresthesia, paralysis, and pallor. Like I said before, if they have an extensive amount of phantom pain, the physician can order IV calcitonin to stop this phantom pain. Weight-bearing status. You need to look at the chart on page 1554. Which tells you the different statuses, like non-weight bearing, touchdown weight bearing, or toe touchdown weight bearing. Okay, partial weight bearing, and all of those, and know specifically how to do each one of those. You need to know how to, your patient is mobile with crutches. How do they crutch walk? The different variations of crutch walking, please. Okay, some of the complications from trauma and surgery that you're going to see are compartment syndrome, which occurs due to internal pressure and external pressure, like cast or dressings or clothing. Rhabdomyolysis, which we've talked about earlier. Venous thromboembolism, which can be either a DVT or a PE. DVT may present with signs and symptoms, but a PE a DVT may not present with signs and symptoms, but the PE is going to have signs and symptoms of anxiety or feeling of impending doom, coupled with dyspnea. Fat embolism syndrome, cast syndrome is another problem. You want to check their pulse ox, and these patients, if their pulse ox is abnormal, they need to be sent to the ER if they're complaining of dyspnea on the cast syndrome. A patient with a PE may have acute onset of chest pain, shortness of breath, decreased sensorium, and pink frothy sputum, tachycardia, and tachypnea. Your fat embolism syndrome, that can produce multiple organ failure from emboli, and it can cause or it can initiate an inflammatory cascade that can lead to respiratory failure and neurological dysfunction. A triad of symptoms of acute respiratory failure, neurological dysfunction, and a petechial rash are common with this. You need to see page 1557. Fat embolism also promotes ARDS in patients. Let's talk about cast syndrome. You need to know about cast syndrome. It can be fatal due to compression of the mesenteric artery in the duodenum. Signs and symptoms are going to be vague abdominal pain, pressure, distension, and irritability, followed by nausea and projectile vomiting and bowel obstruction. Early treatment of this is essential. Excuse me. So if you have a patient that is that comes to see you that has on body cast, and they're telling you that every time they eat they're throwing up, then you need to automatically think of cast syndrome. Complex regional pain syndrome. This is often seen with above-the-knee amputations. It's diffuse, persistent pain that can be prevented with early rehab. Pressure ulcers, osteomyelitis, hardware infections. We've already talked about some of these. Joint dislocations, heterotropic ossification, osteonecrosis or avascular necrosis and psychological issues can all be seen with these patients that have had trauma or surgery. Okay, that's all I have for you. I hope this helps you a little bit. If you have any questions, as always, please feel free to text me or send me an email, and I'll help you as much as I can. Thank you. Goodbye.